Good morning, guys. I'm going to record lectures for next week for chapters 51 and 52. This is chapter 52. I'm doing this one first because it's a little more in-depth and kind of a lot to cover. I'm going to try to keep this video 30 to 45 minutes, keep it short. Feel free to pause, come back, watch it again, rewatch it. But again, I'm hoping that I can record this lecture so you can go back and watch it anytime. And you can also watch it and prepare to come to class. And then we can do reinforcement of course, what is covered in this video, questions that you guys have, etc., to really kind of reinforce what we're learning instead of me just talking to you guys for 3 hours in class and then sending you home. So I'm hopeful this is going to work, and I think if you guys give it a chance, it really will. But you have to watch these videos and take notes before you come to class. And then what we do in class is just going to reinforce that and give us extra time to discuss and enforce those key concepts. So if we give it a real shot, I think this will really help you guys. But again, you've got to watch these videos and take notes before you come to class. So I'm going to get started. We're talking about lots of really fun stuff today. Endocrines, kind of one of my favorite topics. I'm really excited. I'm going to share my screen with you. It's just a second. Let's see. Okay. All right. Okay, so we're going to talk about a lot of different disease processes here, and I'm not going to get into the nitty-gritty crunchiness of the endocrine system. I feel like if you've had anatomy and physiology, you should have a baseline understanding of what hormones are, how they work in the body. You may have to go back and kind of refresh your memory on which endocrine glands secrete which hormones and kind of how they work in the body, but we're going to talk about specific hormones and specific disease processes that you're going to likely encounter in patients that are, really high incidence occurring disorders, and obviously ones that you're going to see on the NCLEX as well. So I'm trying to narrow down what I think is important for you guys to study in these chapters. So I want you to listen closely and take notes, because a lot of the questions on the last test were things that I spoke in my lecture. So if you hear me say something in my lecture and then you hear me talk about it again in class the next day, put a big red star next to it and then go back and study that, because I'm trying to point you guys in the right direction of what I feel like is important for you to study. So with that being said, let's just talk a little bit about the endocrine system and what its main function is. So we know that it regulates our cellular interactions. It helps regulate our growth, our metabolism, our reproductive system, and it works and is closely interrelated with the immune system and the functions of obviously a lot of our body organs. So we're going to focus on disorders of the thyroid, the parathyroid, the pituitary, and the adrenal glands. So those are the main ones we're going to focus on. There's other chapters where we cover reproductive later on. So it's important to know like what glands secrete what hormones, but we're not going to get into the nitty-gritty crunchiness of sexual function and that kind of stuff in this chapter. Okay. So what are our major hormone secreting glands? Obviously, we've got our hypothalamus, our pineal gland, our pituitary, or the hypophysis, the thyroid, the parathyroid, our thymus, our adrenals, our islets of Langerhans, and the pancreas. And then, of course, our gonadotropic ones, so testes and ovaries. What type of categories of hormones does our body make? We make amines and amino acids. Those would be epinephrine, norepinephrine, and thyroid hormones. And then we have peptides, polypeptides, proteins, and glycoproteins. So that would be our thyrotropin releasing hormone, or TSH, the follicle stimulating hormone, FSH, and growth hormone, or GH. And then steroids, pretty self-explanatory. So we've got our corticosteroids. Those are the hormones that are produced by our adrenal cortex. And then we have fatty acid derivatives, which are retinoids. If you guys look at table 52.1 in your book, that lists the major hormones and the target tissues. When we're talking about doing A&P review, this is a really good place to just go and look and just kind of refresh your memory, like, oh, this makes this hormone and this is the tissue it targets. Just a refresher. But like I said, I'm not going to spend time lecturing on that. That's something you need to go and look and refresh out, on your own. Some people may remember it great. Some people will struggle with it. So really just depends on how well you feel like you know it and on how much time you need to spend reviewing it. The amount of hormones we have circulating at any time depends on, obviously, our body's needs. But ideally, our hormones are going to stay at a normal, constant concentration, so that we don't have accumulation of these hormones. Our body regulates these continuously by what we call the negative feedback system. And you're going to hear me say that pretty frequently as we talk about each one of these. But that's so that, or if our hormone concentration increases, further production of the hormone is stopped, or decreases, or vice versa. If we have too little of the hormone in our blood, then it's going to increase the stimulation of that hormone to bring it up. So that's the negative feedback system and how that works. So let's talk about our pituitary gland, or hypophysis. This is located in the inferior aspect of the brain, and we have it further divided into lobes. So we have an anterior and a posterior lobe, and those are controlled by the hypothalamus. And if you guys remember anatomy and physiology, the hypothalamus is connected to the pituitary gland by the pituitary stalk. So from the little tail that connects it. The hypothalamus is responsible for secreting our antidiuretic hormone and oxytocin, and transfers those to a storage facility, which is our pituitary. The posterior pituitary produces antidiuretic hormone. So when you're thinking of these names, think, okay, well, I know what a diuretic is, so what is an antidiuretic? And that can kind of maybe clue you into the job function of that hormone. But we have the antidiuretic hormone, or also known as vasopressin, and this stops the body from releasing fluids. So it works on the kidneys and keeps fluid in the body and not in the potty. So that's another way you can remember that. What if we don't make enough, or we make too much antidiuretic hormone? And that's a couple of the disease processes that we're going to talk about. So if we make too much antidiuretic hormone, what do you think might happen? Ask yourself that question at home. Okay, so we're going to talk about SIADH as kind of a mouthful, the syndrome of inappropriate antidiuretic hormone, where we have too much or excessive production of ADH from the pituitary gland. So if we think about ADH as an antidiuretic, what does that mean? Well, what does a diuretic make you do? It makes you pee. So an antidiuretic would make you what? Not pee. It make you keep your water in your body. So if we have way too much of that hormone that makes you keep your water in your body, we're going to swell up really big. We're going to have decreased urine output. So you can see this. I totally did not make this. I stole it from the guy online. Anyways, he's got really good videos I'll post for you guys to watch too, but I stole these images from him because they're really good. Not gonna lie. But patients with the SIADH cannot excrete or dilute their urine, and they retain that fluid. And that's going to help. I mean, that's going to contribute to all these signs and symptoms we're going to see. I was preparing for my lecture, and my husband was asking me what I was lecturing over and I told him SIADH, and he just graduated LP in school. They touched the surface on some of this stuff, and he said, oh, that's the one with too many letters, so that's too much water, when differentiating between SIADH and diabetes insipidus. And I was like, oh, that's a really good memory trick. I'm going to share that. So too many letters, too much water, that might be a memory trick that might help you guys when you're thinking about SIADH versus diabetes insipidus and trying to remember which one's which. So, and too much antidiuretic hormone, we're not going to diurese because we have too much antidiuretic hormone. So we're going to hold all our water in our body and not in the potty, right? So what are we going to see? We're going to be soaked inside, right? We're going to have all that fluid is going to be kept inside. So we're going to have fluid volume overload. So when we have fluid volume overload, just like we've talked about in different chapters, we're going to have increased blood pressure, and then we're going to hemodilute, right? So we're going to have too much water. Just think of it, everything is just liquidy and soggy inside. So we're going to see dilution of our electrolytes as well. So we're holding on to all that fluid. We're going to have dilution of the electrolytes, specifically sodium. So write this down, make a note. With the SIADH, you're going to be hyponatremic. And that's because we have so much water that it's diluting the sodium. So you just, the sodium levels are going down just because we have so much water. This can be life-threatening. It can lead to swelling in the brain, seizures, and death in these patients. So it's pretty serious, and you can see really, really low sodium levels in these patients. So that's your kind of your red flag that this can kill you kind of thing. So know that that is related to the hyponatremia. So some memory tricks on remembering this is our 7 S's. So the first S is we're going to stop urinating, right? Because our we have too much of that ADH, and it's sending the signal to the kidneys to don't let that water go, hold on to it for dear life. So are these patients going to have a lot of urine output? No. Very low urine output. So we have very low urine output. What's our urine going to look like, the little that we do put out? It's going to be super thick and super concentrated. So we're going to have a high specific urine gravity greater than 1.03. So be thinking we're just so swollen up and full of water on the inside. A little bit of urine we make out is just going to be like thick, concentrated, sticky urine, right? We're soaked on the inside. So think everything is going to be low and liquidy and just kind of drenched in water. So again, that low hyponatremia, that sodium less than 135. S, so a sign when our sodium is low. Headache is an early sign of hyponatremia. So we want to watch for a patient who complains of a headache. That would be an early sign for hyponatremia. S, seizures. Early sign of low sodium is headache, and then later signs we can have confusion, and then really, really late is these patients are going to experience seizures and swelling in the brain. So not good. And then we again have that fluid volume overload. So our next S is severe high blood pressure. So just think like we're just like so swollen and everything inside. We just have way too much fluid. And that's making our blood pressure go up. And then the last S is stop all fluids. So if we have somebody who's just like this super soakered person, do we want to encourage them to keep taking in a lot of fluids? No, right? So we're going to stop all fluids because we have the low sodium already and we don't want to further hemodilute them. And then we also want to discourage that fluid intake. And we can give salt because we have low sodium, right? And diuretics because we need the body to diurese. And we can also treat the hyponatremia with the 3% normal saline solution as well. So what are some things that can cause this SIADH is our pretty common one is severe brain trauma. So we just have brain trauma and the pituitary gland just gets dysregulated. Sepsis or infection of the brain, so like a meningitis infection. And then another one is small cell lung cancer. Can put patients at risk for this. So nursing interventions, we want to closely monitor daily weights, strict intake and output, and neurologic status is very, very important. Okay, so SIADH, too much antidiuretic hormone keeps the water in the body and not in the potty. So when you're thinking about those signs and symptoms, just think about this blue man here who's just full of fluid and what that might look like clinically. Okay, so on the opposite end of the spectrum, when we don't have enough antidiuretic hormone, what do you think is going to happen? We are going to get rid of way more than we need to, right? So if we have a deficiency of the antidiuretic hormone, so not enough antidiuretic hormone, the nephrons in the kidney don't get told to hold on to that water. It just, think of it as just leaks out like a sieve. Like the kidney's like, hey, nobody's telling me to hold on to this. I'm just going to let it go. We don't have enough antidiuretic hormone. So the water goes into the potty. Think ADH. ADH is dead. Diabetes insipidus. ADH is dead. So we cannot keep our water in the body. It goes in the potty. So we're going to see large volumes of water loss in these patients, like liters a day, like 6 to 10 liters a day, probably, if not more. They're just going to be urinating and peeing like an elephant all over the place. So what can some causes of this be? Again, trauma to the head, which is dysregulation of the pituitary gland, or tumors of the pituitary gland, damage to the brain, so those type of things. So of course, you know, with these disorders, we need to treat them, but we also need to try to find out what's causing them for potential reversal of these disorders. So for diabetes insipidus, let's think of the 7 Ds of diabetes insipidus. So the first D would be diurese. So we're diuresing like crazy. Drain fluid, we're going to have high urine output. So think about how our urine was really thick and sticky with SIADH is going to be the opposite with the diabetes insipidus, because we have so much urine just coming. I mean, it's going to just look straight like water, not even like urine. It's going to be super diluted. We're going to have that dilute urine, and it's going to have a low specific gravity of less than 1.005. So low specific urine gravity. And just think, like with the SIADH, we were super wet inside. With the diabetes insipidus, we're going to be dry inside. And then you can DI, diabetes insipidus, or dry inside. Sorry, I don't know how to turn that down. Okay. So, sorry, I'm in Miss Barbara's office. She's popular apparently. So dry inside, gotta find out where it was. I lost my place, lost my concentration. Dry inside, high and dry. So think high and dry. Diabetes or SIADH was super liquidy and wet. Diabetes insipidus, we're going to be super dry because all our water is going in the potty, right? So if all our water is going in the potty and we have thick viscous blood, what electrolyte disturbance do you think we might have? Hypernatremia, right? So we're going to have that super concentrated hypernatremia instead of super diluted sodium now. So we're going to have that signs and symptoms of hypernatremia. Your patients are going to have super increased thirst. They're going to be just dying for water, just, you know, want to drink all the water in the world. So they're going to be drinking lots of water, which is called polydipsia. Okay. So they're just going to be just like chugging water, just feel like they can't get enough. They're going to be obviously like outward signs of dehydration, right? Because we're just super, super dry. So dry skin and dry mucosa, dry cracked skin, you're going to see that. And then if we don't have enough fluid volume, what's our blood pressure going to do? It's going to do the opposite of that SI-ADH. It's going to be really low because all our water is going out. So we're going to have a decreased blood pressure. We're going to be dehydrated. We're going to be dry inside, and we're going to have just straight water looking urine that's going to be super diluted. And so the last D is what our treatment is, which is desmopressin. Desmopressin is a synthetic vasopressin or antidiuretic hormone. So what it's going to do is it's going to act on the kidneys and it's going to say, hey, keep that water inside. Let's hold on to some of that water. So it's going to add our ADH and it's going to decrease our urine output, which is going to increase our blood pressure and kind of regulate this syndrome. But again, like I said, we need to treat it, but we also need to look and see like what's causing it, what could have caused the disorder in the first place. So nursing care, again, strict eyes and noses is very, very important. Daily weights, weight gain equals water gain, right? And weight loss equals water loss. So just think that on both of these patients, what we're trying to consider. Okay, so again, let's review. SI-ADH, soaked inside. We have syndrome of inappropriate antidiuretic hormone. That's a mouthful. But again, we can't excrete or dilute the urine, so we're going to retain all that fluid and we're going to develop the hyponatremia and low liquid elab, so that hyponatremia, those signs and symptoms, headache, confusion, severe high blood pressure, low urine output. Diabetes insipidus, we don't have enough antidiuretic hormone, so everything leaks out the body and we're going to be super, super dry. High urine output, low urine gravity, dry inside, dehydrated, can't get enough water, drink. Treat it with desmopressin. Okay. We're going to reinforce this and practice it again in class because I want you guys to just be able to spout off what this stuff is. So I really want you to sit down, take notes, map it out, make it make sense to you when you're writing your notes, write them out side by side, compare them. You're really going to have to do a lot of work on studying on this to get it straight in your head. At least I know I did when I was in school, and even refreshing to teach it to you guys. Okay, so let's talk about the thyroid gland. The thyroid gland is our largest endocrine gland, and it's a butterfly-shaped organ. It sits right here, and we have two lobes when we talk about the thyroid gland. The main function is to control cellular metabolic activity within the body. Also remember that we need iodine for synthesis of our thyroid hormones. And where do we get a lot of our iodine in our country, or in our diet, in our American diet? Table salt. So we have some hormones here. We have thyroid stimulating hormone that's secreted from the anterior pituitary gland. And our thyroid stimulating hormone stimulates our T4 and our T3. Those are our active thyroid hormones. And then we also have calcitonin, which is made by the thyroid gland. So when you're thinking about calcitonin, a memory trick is it puts a ton of calcium in the bones, calcitonin. So this tones down the calcium in the blood. So that regulates our blood calcium levels, right? Okay. So these hormones are synthesized and stored bound in proteins in the cells in the thyroid glands until needed for release in the bloodstream. So again, we have our negative feedback system working in here. So TSH controls the rate and release of our thyroid hormones. So if we have, if the thyroid hormone concentration in the blood decreases, we're going to have that release of the TSH, and that's going to increase the output of the T3 and T4 and vice versa. If we have too much T3 and T4, it should slow down the release of TSH, which is going to slow down the release of the hormones. So we've got that negative feedback system. But when we're looking at labs, we always want to focus on T3 and T4 first. So we want to look at those labs in our patient first. So if we have T3 and T4 and those levels are high, that's hyperthyroidism. And then if we have T3 and T4 that are low, we have hypothyroidism. And just think that your stimulating hormone for those are always going to be the opposite. So if your T3 and T4 are high, then your TSH is going to be low. And if your T3 and T4 are low, then your TSH is going to be high. Okay, so we've got that negative feedback system. So let's talk about hyperthyroidism. We have, obviously, what we say, too much T3 and T4 are being produced in the body. And the number one cause of this is autoimmune disease called Graves' disease. So this is where we have high levels of T3 and T4. That's the number one cause. Some other causes can be iodine excess. And also when we're treating hypothyroidism, we can cause hyperthyroidism by giving too much of our synthetic thyroid hormone, so levothyroxine. So we have to be careful when we treat the opposite disease, because it can cause the reciprocal disease if we treat it too aggressively and we're not monitoring our patient's response to the treatment. But again, that number one cause is going to be Graves' disease. That's an autoimmune disease. Okay. So some classic signs of our hypothyroidism and Graves' disease are our grape eyes. This is known as exophthalmos. So we've got the large, bulbous, protruding eyes. And this can be difficult at night for patients because our eyes are protruding out and we don't have enough eyelid to cover the eye, so their eyes can get dry. So we can tell our patients at night they can put an eye patch over their eye, a pad, and tape it down to help with that. And then we have our golf balls in the throat, or our goiters. So that is the big bulge here in the throat, and that's the enlarged thyroid gland. And it's not necessarily always this exaggerated, but if you've ever, been walking around even before you were a nurse or a nursing student, and you're like, man, that person's eyes look, they're big old bug-eyed person, they probably have hyperthyroidism. Or if they have a big old goiter in their neck, hyperthyroidism. So if you're ever walking around and you see somebody like that, that's a classic sign they suffer from hyperthyroidism. Those are very obvious outward signs that we can see that people may not know. They may not know. So, if it's a patient that comes in and, hey, have you ever been, I don't see hyperthyroidism on a chart. I wonder if they've, ever been tested for that, or, they're just coming in because they got a sore toe. So just, be conscious of those when you see them. So with hyperthyroidism, everything's high. We're going to have high blood pressure. We can have hypertensive crisis. So this can be occur for a blood pressure of 180 over 100 systolic. So the blood pressure can get super, super high. This can cause MI, CVAs, aneurysms, all those complications that are associated with hypertension. So that's no bueno, right? And then we have tachycardia, so high heart rate tachycardia. So we're going to have elevated pulse over 100. This can also have them cause them to have heart palpitations and AFib, because the hyperthyroidism makes the cardiac tissue more susceptible to those catecholamines, which are norepinephrine and epinephrine, and so it can cause them to have those heart palpitations and dysrhythmias along with the hyperthyroidism. And then they're going to have high metabolism. So super high metabolism is going to be what? Weight loss. Everybody's like, oh, I'll just take hyperthyroidism for a couple months. But there's lots of really other bad things with it, so I wouldn't wish it on anybody. But they're going to be a lot of times losing a lot of weight when they develop this. So this is our little skinny tiger over here that kind of lets you know, like, this is just a really good visual for our visual learners out here. But we've got our little skinny tiger right here. So that high metabolism is going to cause weight loss because they're burning just a ton of calories. High temperature, but not dry. So they'd be hot and sweaty. So let's see this little tiger's face, and even especially in fairer skinned people, you're going to see redness in their face, and they're going to be diaphoretic. They're not hot and dry, they're hot and diaphoretic. And they have heat intolerance, like, oh my gosh, just can't stand the heat. And And then we're going to have high GI overactive GI tract. So just think like everything's going to be high blood pressure, high pulse, high metabolism, high temperature, overactive GI tract. So we have overactive GI tract. It's moving. It's going to like just move food straight through, and your patients are going to be having diarrhea. So we already have a high metabolism, and then maybe our food's not getting digested well enough because it's just moving straight through our GI tract, which makes their weight loss even more compounded. So what are our treatments for our hyperthyroidism? There's a couple of medical treatments, medications, the methimazole or tapazole, and then, y'all, I'm gonna try and say this right, propylthiouracil or PTU. And these both block the synthesis of the thyroid hormones. So that's how they work. We do need to wash cautiously because these medications can cause Stevens-Johnson syndrome, or that topic epidermal necrolysis that we talked about last unit on the last test. So just, of course, watch closely for those. And then they have the potassium iodine, and that actually is used to shrink the thyroid. So if the hyperthyroidism is really extreme, then we can do a thyroidectomy, which we'll talk about in just a minute. But before the thyroidectomy, if we have a really big and large thyroid, we can give them this potassium iodine, and it can shrink that thyroid down a little bit before we take it out. The nursing indication on this medication is to tell them to drink it through a straw because it can stain their teeth, like a brownish color. So drink it through a straw. And then remember how we said we had that high heart rate, that high tachycardia, that high blood pressure, so we can help treat the symptom of that with a beta blocker. So we know beta blockers are going to lower our blood pressure and our heart rate. So we've got our anti-thyroid medications, the methimazole, the tapazole, or the PTU. Those block synthesis of the hormones. The potassium iodine can shrink the thyroid, and we have the beta blockers that can treat our cardiac symptoms secondary to the hyperthyroidism. And then we have radioactive iodine uptake. And this is actually going to just come in and just destroy the thyroid, just wipe it out, like wipe that function out. It's just going to just kind of go in and turn the thyroid off, okay? And this is usually just given in one dose, and one dose should be enough to shut it down. So when we're preparing the patient to have this procedure, we want to make sure they always have a negative pregnancy test prior to obviously having this done. We're going to instruct them to remove jewelry, dentures, those things, on or around their neck and their mouth. 5 to 7 days before the treatment, we want to hold any of those anti-thyroid medications, Surafon, that tapazole, or that PTU, and then we're going to do the radioactive iodine. We need to educate the patient 5 to 7 days before we do that procedure. You need to stop taking those meds, hold that med. They're usually awake and not sedated during this procedure, so they only have to be NPO for 1 to 2 hours before and after. And then again, when we're talking about any kind of radioactive procedure, whether it be for this or cancer or whatever, our patients are going to be radioactive for a period of time afterwards. So I know the Hearst lady talked about it with you guys, but some of those things that we're going to do during this radioactive period is we want to tell them to avoid crowds. They kind of just need to isolate themselves. So within their home, they need to sleep in their own bed, not with anybody else in the bed with them. They need to use their own bathroom. They don't want to share the bathroom because their bodily fluids can be radioactive. When they pee, they need to flush the toilet 3 times. It's like flush, 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 and get all that radioactive urine out of the potty. They want to avoid being around pregnant women, around children. They also don't want to share any kind of utensils like forks, cups, anything like that. They may have their saliva, and then they also should wash their laundry separately. So they really just need to isolate themselves. And they say anywhere from 3 to 7 days. So I guess maybe it just depends on the amount of radiation that they get through this. But I would err on the side of caution and just say, for 7 days, they need to to use these precautions after they have that radioactive iodine. Let's talk about diet for people with hyperthyroidism. So if we're having a super high metabolism, what do we need? We need to increase our calories to meet that metabolic demand. So these patients are going to need a higher calorie diet, so 4,000 to 5,000 calories a day. And that's kind of hard for some people. So frequent meals, frequent snacks, maybe they can't sit down and eat a whole, 2,000 calorie meal all at once. So they may just have some of those high protein, high calorie snacks frequently throughout the day to meet their caloric demands. But specifically, we want high protein and high carbs for these people. And then we want to avoid high fiber because their GI tract is already overactive. So we don't want to give more fiber and make the diarrhea or the overactive GI tract worse. And then again, what are some things that stimulate the GI tract? Caffeine, soda, tea. So we don't want any caffeine. So we want to avoid all that. And then also spicy foods. So they should avoid, like super spicy hot Cheetos or whatever. Probably shouldn't be eating those. Okay, and then what's our extreme emergency need to watch for these signs and symptoms with hyperthyroidism is the thyroid storm. So if you guys will look at chart 52.6 in your textbook, that goes over the thyroid storm, but we're going to see extreme highs. So we already know everything's high in hyperthyroidism, but this is going to be like extreme life-threateningly high. So they're going to have agitation and confusion, extremely high temps. This can be up to like 105 temperature, extremely tachycardic, extremely high blood pressure. So we've got to get this under control. So our treatments are going to be, we can use hypothermia blankets. We're going to want to put oxygen on them because that's going to assist with that increased metabolic tissue demand that we have with the high blood pressure and high metabolism and tachycardia, so O2. We're going to treat it with that anti-thyroid medication, so that PTU or that Tapazole, methimazole. We can again give the beta blockers to help control the heart rate and the blood pressure. And then we're also going to give corticosteroids to treat and prevent shock from adrenal insufficiency. So look over that thyroid storm chart in chapter 52.6 and just be familiar with that and what the signs and symptoms and treatment of that are. But we know with everything that thyroid is high, but this is when we get like that life-threatening high. Okay. All right, so let's talk about a thyroidectomy. So this can be used to treat thyroid cancer or extreme cases of hyperthyroidism, or in people who couldn't have certain antithyroid medications, like pregnant women or those who may be allergic to antithyroid meds, or maybe patients who have like really large borders in their neck and we need to do that thyroidectomy. So like I said, before surgery, we're going to hold those antithyroid medications until we have, or 7 days, 5 to 7 days before surgery. When removed, the thyroid hormones can be released systemically. So if you think like, just kind of think of it as like a little sack that's holding, thyroid hormone. And when you take it out, I mean, they try to be really gentle, but they can sometimes release or squeeze some of that thyroid hormone systemically. So in that immediate postoperative period, we're going to watch for signs and symptoms of hyperthyroidism or that thyroid storm in that immediate postoperative period. So if you get a test question that says, hey, this patient just had a thyroidectomy and their blood pressure is super high and their temps high, be thinking thyroid storm. Or you think, why would they have a thyroid storm? They just took their thyroid out. Because of that release of the thyroid hormone when they take it out. So be thinking of that. So what are some important nursing interventions in patients who's had a thyroidectomy? So our airway. Since surgery is done around the neck, this is really important, right? The airway is always important to assess, but especially when we're having like neck surgeries. So we want to watch for laryngeal stridor, noisy breathing, hoarseness. Those might be key words that you would hear on a test or see on an NCLEX exam. And that's going to indicate that you have an airway issue. So if you see laryngeal stridor, noisy breathing, hoarseness, those are key words that clue you in that something in the neck, in the airway is not right. So what's our number one priority for a patient when we're assessing if they have those will be to maintain that patent airway. So our number one nursing priority is to have an ET tube or a tracheostomy kit at the bedside. You may commonly see that on an NCLEX exam. So number one priority, have those supplies ready, be ready to establish a patent airway if needed for these patients, or to notify the physician. Obviously breathing, is important. We talked about that. Circulation. So bleeding around the insertion site. So we want to monitor for potential bleeding and hematoma formation. We want to check that dressing, look for bleeding, around the neck or on the back side of the pillow. And the neck alignment is really important because we want to keep the integrity of the sutures and the surgical incision. We don't want to hyperextend it, and we don't want to hyperflex. So we want to keep the head and neck in a neutral position. So when we're talking about how you should position this patient in the bed, we don't want them to be supine. We want them to be at a 30 to 45 degree angle, which would be semi-Fowler's. So no flexing, hyperflexing, or extending the neck, because that would put pressure on that suture line, and then we could have bleeding and hematoma formation, and not good things happen because of that. And then we need to talk about calcium, and we're going to talk about the parathyroid hormone here in just a second, or the parathyroid glands. But the parathyroid glands are situated posterior to the thyroid, and they're just like little kind of dots glands, and sometimes they can be embedded within the thyroid, and so even skilled surgeons who've done, tons of thyroidectomies can have accidental removal of this thyroid gland. So we want to be really careful and watch for signs and symptoms of low calcium, hypocalcemia, because our parathyroid glands regulate that. So if our calcium is less than 8.6, our normal calcium level is 8.6 to 10.2. If we remove the T, the thyroid gland, we check the C, the calcium. So we're going to monitor for those signs and symptoms of hypocalcemia. So early signs of low calcium, we might have circummoral tingling or tingling in the fingers. That tracel, which is the arm jerking, we put the blood pressure on, we're going to see that tonic muscle jerking in the arms, and the shabaks, which is the cheek muscle rigidity. So those would be your signs. Going back to fluid and electrolytes, your signs of hypocalcemia, and be thinking about that after the thyroid is taken out. So hypothyroidism, we have low and slow. We have a low T4 and a low T3. This can be caused by low iodine levels in our diet. Like I said, in most developed countries, we get our iodine from our table salt, so that's not super common for us. And the most number one cause of this is Hashimoto's, which is an autoimmune disease. So we have the Graves', which is an autoimmune that can cause hyper. And we have Hashimoto's, so think moto, loto. So moto, loto, Hashimoto's is going to cause that hypothyroidism. Again, the low iodine in the diet can be another cause, pituitary tumor, and having your thyroid removed. It's going to cause hypothyroidism, right? Because we're not going to be releasing any thyroid hormones once the thyroid's removed. So, so our classic signs and symptoms, everything is low and slow. So we're going to have low energy, fatigue and weakness, low metabolism. So we're going to have weight gain. You can kind of see this little puffy looking little Eeyore over here. And he's sad. He has a low mood. So he could have depression, apathy, loss of hair. So alopecia. So they can lose their hair. Low libido. So low sex drive. And then we're going to have dry skin. And then just think about the opposite of the GI tract excitability that we had in the hyper. We're going to have the opposite in the low. So the GI tract is going to be really low functioning. So what do we have? We have a slow GI tract. We're going to have constipation. So just think the signs and symptoms really are just quite opposite of each other. They can also have low and slow menstrual cycles, so they can have missed periods or even amenorrhea, or a slow heavy period, which is hypermenorrhea. So our treatment for this is levothyroxine. We want to really stress to our patients that this is not a cure. This is a hormone replacement, and it's going to be a lifelong drug. They're going to have to take this for the rest of their life. There's no, oh, I'll take it and feel better in 6 months. No, you're going to have to take this hormone replacement. It's not a cure. It's just a replacement of this hormone, but you're going to need it for the rest of your life. And we also want to educate them that this, when they initially start this therapy, it can have a slow onset. So it could be 3 to 4 weeks before we see full onset of that thyroid hormone correcting those symptoms of the deficit of thyroid hormone. So teaching for the levothyroxine, they want to take it early in the morning on an empty stomach, 30 minutes before they eat, 30 minutes to an hour before they eat, but ideally at least 30 minutes. So we can tell them like, hey, first thing in the morning when you get up, take that Synthroid with a glass of water, or, water on an empty stomach, nothing else. And then later on, you can take your other meds, but it can interact with other meds. And so we want it to be alone by itself in the stomach. We wanted to monitor for signs and symptoms of hyperthyroidism, because we're giving a synthetic hormone, and of course we can give too much or too little, but too much is a problem. So just like I said, that could be a cause of hyperthyroidism, is this giving the synthetic thyroid. So they're going to need to have their labs monitored, obviously, on a routine basis. They don't want a double dose if they miss a dose. They just need to take it as soon as possible, but they don't want to take double dose at the same time. And they never, ever should stop abruptly taking the medication. Cannot stress that enough, because this can cause, again, we had our thyroid storm with our hypothyroidism, and our thyroid storm with hypothyroidism is not a thyroid storm, but it's called myxedema coma. And this is the life-threatening symptoms that can happen from the extremely low or absent thyroid hormones within the body. So just like our thyroid storm was just super, super high, our myxedema coma is going to be everything is super, super low. So we're going to have a really low respiratory rate, which can lead to respiratory failure. So our priority bedside nursing interaction, again, if we have chance for respiratory failure, what are we going to do? We need intubation stuff at the bedside. We need to watch for that. We need to be prepared for that. Low blood pressure, low heart rate. So we're going to see this patient's going to be hypotensive and bradycardic. And they're going to have a super, super low temperature as well. So they'd be hypothermic. And I have a story for you guys I'm going to share. And again, I'm trying to keep this short, but I'm also trying to be thorough. So back in November, I was working on the floor and I took a report on a patient. And she had come in, initially the family had thought she had had a stroke, because she kind of had some, some change in her mentation, her level of consciousness. She'd been really tired, couldn't get up, speech was kind of not normal, not making sense. So they thought she had a stroke. Family brought her in, thought she had a stroke. It ended up being myxedema coma, because she had just decided one day, I'm not going to take my thyroid pills anymore. She had actually stopped taking all of her medications, but specifically the thyroid pill is what caused this. So it had been probably about 2 months since she had had her thyroid medicine. And I got a report on her, and I'm like, man, this is interesting. I've never had anybody with myxedema coma. I was like, this is kind of cool. I saw that on the report sheet. And then I got a report and I was like, this is not cool. Because she, I guess, had been doing okay, on admission, and then things had gotten worse. And I got a report, and her temperature, the nurse said, well, I went to take her temperature and I scanned her with the temporal, and it was 95. And I was like, oh, that can't be right. So I scanned her again, then it was like 92. And I was like, something's going on here. So she went and got a rectal, took a rectal temp, and it was 88. Her rectal temp was 88 degrees Fahrenheit. And she checked it several times, and that was correct. So she was super hypothermic. Her pulse was low, her blood pressure was low, her mental status was, she was unresponsive basically at the time that I took report from her. I'm like, what are we doing? What are we doing with this girl? She's on a med-surg unit. I'm like, oh my gosh, you know. And they were like, well, we put the bear hugger on her, and they said as long as her like blood pressure and pulse maintains, that she should be okay. Well, I got a report on her, and then immediately went back in to do my assessment. Took her first set of vitals. Her blood pressure was like 70/30. Her pulse was like 42. Her temp was still really low, and her respiratory rate was like 12, and her sat was 60. I mean, we were like minutes away from coding her. I was like, oh my gosh. So anyways, I called our rapid response team, and we ended up getting her to the ICU, and we have a really great hospitalist, and he was like, yeah, this respiratory failure, you know. So respiratory failure and these patients, you want to monitor really closely for it. And then just know that you're also going to have that low blood pressure, low heart rate, and hypothermia. And those are your medical emergencies. So she ended up not having to be intubated. They, I think, put her on a BiPAP for a while, and she was okay. So, but this is why we stress, don't stop abruptly taking your thyroid medication, because it can be really, really bad, right? Okay, so diet for these people who have hypothyroidism, obviously, you know, we have our slower metabolism, so we're going to need lower calorie or lower fats because our metabolism is slow. And we can also tell our patients they need those frequent rest periods since they have low energy. Also, with our patients with hypothyroidism, we want to avoid or just use very cautiously narcotics and benzodiazepines because everything's already slow. So this can lead to respiratory depression in these patients, especially in the hospital setting. All right, parathyroid glands. So these are these 4 little glands, like I said, that are embedded posterior to the thyroid gland, and they regulate our calcium and our phosphorus balance. Again, we have our negative feedback loop. So the serum level calcium regulates our output of our parathyroid hormone, or PTH. So the increased calcium level results in a decrease in our PTH secretion, and low level stimulates PTH secretion. So we've got that negative feedback again. Just think PTH, put the calcium high, put the calcium high PTH. So that's what it's going to do. And that's how our calcium is regulated. So ways calcium is regulated, we have renal absorption of the calcium back into the blood. We have intestinal absorption through the GI tract. And then we have bones, so we can take calcium from the bones and put it into the blood. So those are just ways that we regulate calcium in our body. So think of PTH as the bully here. When we have hyperthyroidism, we're also going to have hypercalcemia. Okay, or sorry, hyperparathyroidism, we're going to have hypercalcemia. So think of PTH as a bully, and it's squeezing the calcium from everyone in the body. So we're going to have too much calcium in the blood. So when we have too much calcium in the blood, think back to when we're talking about hypercalcemia and fluid and electrolytes. And there's a really good video, and again, not going to take credit for coming up with these acronyms, but they're really good memory tricks, guys. So moans, stones, and groans. So moans is going to make our bones weak. So it's going to take calcium from the bone storage. So this is going to make our patients have brittle bones, right? So they're going to be risk for fractures. Kidney stones. So if we have just a bunch of calcium and the kidneys can't excrete it all in the urine, then it's going to cause renal calculi. So we're going to develop kidney stones that are calcium based kidney stones. And then groans. So intestinal tracts can be overloaded with calcium. Just think hard stones in the kidney, hard poop in the bowels. So we're going to have too much calcium, and it's going to cause hard stools. And then just think about what your signs and symptoms of hypercalcemia are. That muscle weakness, nausea, vomiting, constipation, cardiac dysrhythmias. So the treatment for this hyperparathyroidism is going to be surgical removal of the abnormal parathyroid tissue. Let's see. and hydration therapy. So we want to give them fluid to dilute that hypercalcemia. We want to treat our calcium issues first, and then, treat the cause. So if we have somebody come in, they're hypercalcemic, we're going to treat that electrolyte imbalance, and then we're going to look at, okay, what's causing this hypercalcemia, and it's usually related to the parathyroid gland. So we're going to treat that hypercalcemia first, and then we're going to look at the cause so that, it doesn't continue to occur. So our surgical treatment is that parathyroidectomy. It's essentially the same nursing interventions that you're going to do for the thyroid patient, because it's, almost exact same location. And then we're going to monitor for signs and symptoms of low calcium, obviously, afterwards. So it's important that we have follow-up labs drawn, intake, teach our patients about intake of dietary calcium. Just like we have, too high calcium, we can have a hypercalcemic crisis. This can occur when we have elevation of extreme calcium levels, and this can result in neurologic, cardiovascular, and kidney symptoms that can be life-threatening. So our treatment is rapid rehydration with large volumes of IV isotonic fluids. If you don't know what an isotonic fluid is, please look it up. Some of y'all missed that on the test. Combination of calcitonin. So calcitonin is going to bind with that hypercalcemia and help release that calcium, and corticosteroids in an emergency situation. So the calcitonin and corticosteroids is administered in emergencies to reduce the sodium calcium level by increasing calcium deposition in bones. So hypercalcemia, we have too much or hyperparathyroidism, we're going to have hypercalcemia. So know those signs and symptoms of hypercalcemia. And then obviously hypoparathyroidism is going to equal hypocalcemia. So again, with a hypocalcemia, we have tetany, which is our general muscle hypertone muscle that can cause the tremors and spasms and uncoordinated movement. So we have that Chbosky sign, that's that tap over the facial nerve where we'll see that muscle twitch of the mouth, nose, and eye right there on that side. And then our Trousseau signs, that carpal pedal spasm, that we can occlude the blood flow to the arm with a blood pressure cuff, and then we'll see that spasm in the arm, that tremor of the arm. Diarrhea, circummoral tingling in the fingers. Those signs and symptoms of hypocalcemia and hypercalcemia you'll need to know. So causes autoimmune, so the body can attack this thyroid gland just, or parathyroid gland, just like it does the thyroid. So we can have a parathyroid causes can be thyroidectomy. So when we take the thyroid out, we can accidentally remove the parathyroid glands, and then we're going to have hypoparathyroidism and low calcium levels. Remember when we said we were doing the post-op care for a patient with a thyroidectomy, we're watching for this, right? Because we could accidentally remove the parathyroid gland along with the thyroid. And then radiation therapy. So if we're doing radiation therapy for thyroid, it can also damage the parathyroid. So we want to treat the calcium deficiency, just like we said, we're going to treat the calcium deficiency first, and then, treat the cause of it. So we want to assure a diet high in calcium and vitamin D, and we can give calcium gluconate in an emergency situation. If the patient is requiring administration of calcium gluconate and has a cardiac disorder, they can have dysrhythmias. And so we want to give it slow, give it cautiously, do cardiac monitoring. The care of the postoperative patient who's undergone a thyroidectomy, we just want to, again, watch for those signs and symptoms of hypocalcemia, so tetany, seizures, respiratory difficulties. Okay, we're almost done here, guys. Okay, so the adrenal gland, let's talk about our adrenal glands. This is a lot to cover and it's really crunchy, so I'm trying to keep it short, but sorry, can't say I didn't tell you. So adrenal glands attach to the upper portion of each kidney, right? So we have these little glands that sit right up here. So we have the adrenal medulla. The function of that is as a part of the autonomic nervous system, and it releases our catecholamines, which is epinephrine and norepinephrine. And then we have our adrenal cortex, which regulates our steroids. So glucocorticoids, mineralocorticoids, and then our androgens. The hypothalamus secretes our corticotropin release hormone. Again, we have our negative feedback system here. So the hypothalamus will secrete that CRH until the pituitary gets to secrete ACTH, which is the adrenocorticotropic hormone, and this stimulates the adrenal cortex to produce steroids, which controls our 3 S's, which are sugar, cortisol, the stress hormone. Steroids help to decrease inflammation and swelling from these stressors. Okay, and then we have salt, which is our aldosterone, and this adds salt and water to the body and lets go of potassium. So that's the function of aldosterone. And then we have sex and hair, which is our androgens. So those are the things that this gland regulates. So Addison's disease thinks absence of steroids, we need to add some. Addison's, we need to add some steroids. Okay, so we have an absence of our steroid hormones. Addison's disease, autoimmune, it can be autoimmune, and it can also be idiopathic, or we can have atrophy of the adrenal gland or pituitary gland. It can also be caused by cancer and infection. With our Addison's disease, everything's going to be low. Slow, weak, and tan. We have this little guy over here. He's slow, weak, and tanned. So we have low blood pressure, low weight because we have water loss. We have low temperature. We're going to have cold intolerance. We're going to have low hair, alopecia, low mood, depression, fatigue, low sodium. So they're going to have salt craving, low glucose, and slower absent periods. So 2 areas that are high in Addison's disease are we're going to have hyperpigmentation. So we're going to have bronze pigmentation of the skin, and we're going to have hyperkalemia. So we're going to have a potassium of over 5. And when we have those hyperkalemic patients, again, we're going to watch for signs and symptoms of that, which would be muscle spasms, EKG changes, which are peaked T waves, and ST elevation. Again, with Addison's disease, we can have Addisonian crisis. So look over that in your book. But Addisonian crisis, we have diagnostic tests. We're going to test adrenocortical hormone levels, ACTH levels, and the ACTH simulation tests. So the treatment is to add some steroids for Addison. Okay. So add steroids during time of stress. So any illness or stressor that is going to precipitate problems for these patients with Addison's disease. So if they have surgery, if they do even strenuous exercise, if they have an infection, we're always going to need to add additional steroids to the regimen because that increased stress is going to make the disease process worse for them. They want a diet high in carbs and sodium and in protein. The cortisol helps convert this into energy. And we never want to abruptly stop steroids in any patient because it can lead to Addisonian crisis, right? Again, just like with the thyroid, these hormone replacements, these steroid replacements that we're going to give, is a lifelong drug. It's not a cure. It's just a hormone replacement, but it's not a cure. So we need to tell our patients these are lifelong medications that they're going to have to take. So the 7 S's of our steroid precautions. When we have people who have been on steroids for a long time, they can swollen. So water gain and weight gain. So we want to teach our patients that they have this sudden excess weight gain, then they need to report that. So report 1 pound in 1 day or 2 to 3 pounds within a few days. Sepsis, so they can have an increased risk for infection or illness and delayed wound healing. Sugar, so when we're giving our steroids, it's going to increase our glucose. So these patients are going to be at risk for hyperglycemia. Skinny, so our muscles and bones are going to be more brittle because of the steroids. So they're going to be at a higher risk for osteoporosis and fractures. And then they can also have a slight risk for developing cataracts versus, someone who doesn't take steroids. So anytime we have anybody off steroids, we don't ever abruptly stop them. That can cause Addisonian crisis. We always taper them off. So anytime you have anybody on even just a short dose of steroids, it's always in that Medrol dose pack, right? Where you take 2 twice a day, and then you take, 2 or 1 twice a day, and then you take, you slowly taper off of that steroid. You don't ever just like take it and then done. Stress and surgery, like we said, will increase the need for that additional steroid to add, because we just don't have enough. Just always think, like, when you're going through a stressful time, you release more cortisol, right? Well, these people have a deficit or not being able to produce that cortisol. And so they're going to need more of that natural cortisol that your body would release, or that synthetic replacement of that your body would release during those times of stress. So the Addisonian or adrenal crisis, we have added stress, we have trauma, surgery. Stress will kill these patients if we don't address it early. It can also be caused by abruptly stopping meds, and it can cause an extremely low blood pressure. So our treatment for these people in Addisonian crisis are going to be steroids, IV push, so hydrocortisone and prednisone. We're going to treat dehydration with IV fluids, and then a low sugar with dextrose solution. And then on the opposite side of that, we have too much steroids being produced by the adrenal gland versus Addison's is not enough steroids. We need to add some steroids, right? Adrenal gland's not producing enough cortisol. We need to add some. Cushing's is we have too much cushion of steroid. So that's another memory trick that you can use. So our Cushing's, we have too much cushion. We have excessive adrenocortical activity, or corticosteroids. Can also be caused by long-term use of corticosteroids. Think about people who have asthma, rheumatoid arthritis, people who may have been on corticosteroids for a prolonged period of time. This can cause Cushing's disease. It can also be caused by tumor or adrenal pituitary gland, or again, that small cell lung cancer that keeps creeping up in some of these, right? So small cell lung cancer can cause some of these hormonal balances. With our Cushing's, we have too much cushion of the steroid. So we are big, round, and hairy. Okay, so we have a big blood pressure. So blood pressure over 140. We have big glucose and sodium levels. So we're going to have hyperglycemia and hypernatremia. We're going to have a big belly, also known as truncal obesity. We're going to have a big face, or you've also heard it called moon face. Like, whoever named these was like not PC back in the day. So we have moon face and buffalo hump. So we have a big buffalo hump. I'd be like super offended if it was like the first time I'd ever heard it and some doctor made it up and was like, you have a buffalo hump. I'm like, what? That's rude. So big buffalo hump, or that big fat pad, you guys can see on the back of this person, kind of raised buffalo hump fat pad. Big hair, or also known, a medical term for that is hirsutism. So you could think hirsutism, hairy suit. They're going to wear hairy suitism. So they're going to have lots of hair. And in females, they're going to have hair in places where they don't normally have hair, like facial hair. Big stretch marks, or those purple striae on the face and on the abdomen. Big face, red, rosy cheeks. Big infection, so they're going to have slow wound healing, and then big risk for fractures from brittle bones. So the treatment is to control the cause of what's causing this. So if it's a tumor, we would cut out the tumor. We don't want to remove the whole gland. Or if it's somebody who's on, steroids for RA, we would want, and they start developing Cushing's, we would want to slowly kind of decrease their steroid over a period of time. Again, we're not going to abruptly stop it, because if we abruptly stop it, what can that cause? Addisonian crisis. So we want to slowly decrease the steroids if we can, but that has to be done slowly. They can do a dexamethasone suppression test to test for this. So you may see that done occasionally. So Cushing's, too much cushion of steroids. Addison, not enough steroids being produced by the body, not enough cortisol. So we need to add some. And Cushing's, we have a cushion of it. We have way too much of it. So those are some memory tricks for you guys there. So this is another mnemonic I found, nursing mnemonics and tips for side effects of steroids. There are 5 S's. When people are on steroids, they're going to get sick easier, sad, it can cause depression, sex, it can cause increased libido. That might not be a bad thing. S, salt, retains more and causes weight gain, or S, sugar, raises your blood sugar. So corticoids are used extensively for adrenal insufficiency and are also widely used in suppressing inflammation and autoimmune reactions, controlling allergic reactions, and reducing rejection processes in patients who are having transplantations. Look at table 52.4 in your book and 52.5 for patient education, potential side effects and measures to reduce those side effects. Timing of the doses. So we want to time those to where our body would naturally produce that hormone. So it kind of follows like our body's natural process. So in keeping with the natural secretion of the cortisol, the best time of day for the corticosteroid doses early in the morning, because that's when their body typically normally releases cortisol. So between 7 and 8 a.m. For that large dose therapy at 8 a.m. when the adrenal gland is most active, this is going to produce the maximum suppression. They need to obviously take it as prescribed, required to be tapered. Don't ever stop taking it abruptly. I've said that like 10 times. Y'all better have it written down, because if there's a question like that on the test or the NCLEX, you better not miss it. Corticosteroid dosage are reduced gradually. Okay, that is the end of my TED Talk. I think I've gone long enough. It's been an hour. If you guys have questions, please bring them to class. We're going to do some case studies and practice NCLEX questions. We're going to kind of talk about these disease processes again, work them out, hash them out, but I want you guys to have an introduction, so we're not wasting time in class, me just talking to you. You can watch this video before, and then we can do some more learning activities in class to try to help you understand it and be able to apply it. I'm also going to post a separate video for chapter 50. It's management of patients with biliary disorders, but it's not as crunchy and in-depth in this. It should be maybe a 20-minute video, so I'll try to keep it short because this one was super long. So thanks, guys, and I'll see you next week.